Thank you guys so much for joining us. I'm Lauren Berman. I'm a pediatric surgeon in Wilmington, Delaware at Nemours, and the chair of the Quality and Safety Committee. So have been involved in the effort of APSA to kind of gather and share knowledge around COVID-19 and how we're all coping. So this call was done about a week ago with a different group of people, and we've convened this current group, people from a combination of practice settings and COVID intense areas. We thought we would maybe just start by having everyone just briefly introduce yourself, where you work, what kind of a practice setting it is, and also kind of what the local COVID burden is like in terms of both the pediatric and adult impact locally for you. If we want to just go around, we can start with Marilyn.
Hi, I'm Marilyn Butler. I'm a pediatric surgeon in Portland, Oregon. And I checked the website that estimates when peaks are going to be. And I think our peak is now moving to May 1st. As a result, we've only had about, I think, 16 or 20 deaths and a concomitant number of positive tests. Very little impact on pediatric surgery life at all, other than we've canceled all elective surgery and moved everything virtually, both clinics and educational conferences.
Thank you. David Mooney, you want to go next?
I'm Dave Mooney. I'm a surgeon at Boston Children's, and we're still on the major uptick for COVID cases, but it's been predominantly adults. We've had around 30 staff members test positive. One of a surgeon at our institution tested positive, was in the ICU for a time, but is now back out and is recovery phase. Same, we're not doing much. We've canceled all emergency surgeries. The only people in the building, they're telling us not to go to the hospital unless you're either the person on call that day or you're the rounder. All conferences, even residents are being put in the building if they have cases to do. Other than that, the residents aren't in the building. We're just trying to minimize the number of people. If you go in the building, you wear a mask. They hand you a mask, they check you, do a quick screening for a fever at the door, and they give you a mask. And I'm doing telemedicine visits, stacking up kids with hernias to be done once this is resolved.
Tony, you want to go next?
Sure. Thanks for having me. I am a pediatric surgeon. My name is Tony Escobar. I'm a pediatric surgeon at Mary Bridge Children's Hospital in Tacoma, Washington. Things here in Washington State have been pretty significant, as you probably have seen on the news. Our last numbers that I can quote are near 6,000 cases in Washington State with almost 250 deaths, but the pediatric population has not been hit hard at all. The work environment, or my hospital, is a children's hospital within a hospital. And so we are working very hard to accommodate the anticipated surge, which as of yesterday was going to be April 15th or 16th for us. And so working on expanding the age limits of who we take, how are we going to be able to support our adult colleagues, because I know you may be aware that Seattle and King County have been hit extremely hard, and we're to the south in Pierce County, and we've been hit very hard as well. So that's kind of where we are. We have canceled all elective cases. PPE conservation has been a huge push, and still trying to figure out how we're sharing the ORs with the adults and how do we protect ourselves when we do operate. So it's kind of the lay of the land here.
Okay. Thanks, Tony. Art Cooper, why don't you go next?
Sure. Thanks for asking me to participate. My name is Art Cooper. I'm a pediatric surgeon in a municipal hospital in New York City, Harlem Hospital. Specifically, we also cover Metropolitan Hospital, another city hospital within New York City. As all of you are aware, New York City is now the epicenter of the epidemic in the United States. As of earlier today, Governor Cuomo reported over 3,000 deaths, and In the city, we have 53,000 cases and over 1,500 deaths as of 3 hours ago, according to the latest media reports. Harlem Hospital and Metropolitan Hospital have not been hit hard with respect to pediatric cases. However, Harlem has been very hit hard with adult cases. 2 other hospitals within our system, Elmhurst Hospital and Lincoln Hospital, as many of you may have heard, have been overwhelmed. They've both been on the national news. The trauma centers at Elmhurst and Lincoln have either essentially shut down or are able to really respond only with the minimal capability. Here at Harlem, we've had over 50 deaths over the past week or two. The staff have been extensively redeployed. Virtually every unit has been taken over by COVID patients, including our pediatric unit, which has been turned over completely to our adult colleagues. We have been relocated to another space where we have just a few pediatric beds and just a few pediatric critical care beds available to us. As a pediatric surgeon who has had very, very limited work to do, even on an emergent basis, of course, none on an elective basis, I personally have been assigned to what we call our ILI unit, our influenza-like illness clinic, where patients who are essentially worried well or walking wounded, so to speak, are coming for testing. I do that about once a week, along with all the other surgical attendings in our hospital, of course, with appropriate PPE and so on. But it's an interesting time for all of us.
Thanks, Art. Yeah, you started to talk about one of the big things we wanted to focus on today, which is the fact that this is not something that makes kids very sick, but we're all having to make accommodations to make room for more adults. So you started to get into that a little bit, and I'd love to maybe start with you kind of talking more about that and kind of how it's changed your day-to-day life as a pediatric surgeon, and just kind of physically caring for the adults, making room in the children's hospital, what you as a pediatric surgeon are doing from day to day to kind of help accommodate the adult surge.
Right. Well, we're very much in Tony Escobar's kind of situation, I believe. We're much more of a children's hospital within a hospital. Our unit is relatively small compared to other children's hospitals within hospitals. So our pediatric inpatient census is very low. Our pediatric surgical inpatient census is even lower. I have only 1 patient on the unit at the present time, recovering from a very, very, very bad week-long preoperative rupture of an appendix. Very sick kid, finally getting better, thank God. But again, my day-to-day life in the last week has been focused on numerous conference calls with our system administrators, both at a city level and a state level, and of course, staffing our pediatric surgery clinics, to which very, very, very few patients actually come at this point. And working in the ILI unit, as I mentioned, screening patients for COVID. So that's been my life for the past week. But as is true with everyone, pretty much nonstop on call, day in, day out.
Thank you. Marilyn, did you want to talk about kind of accommodating and preparing for the adult surge?
Yeah, in Portland, we have 2, well, first of all, there are 4 health systems in Portland, Oregon, and they have formed a coalition to try to pool resources to a certain extent. That said, I work in 2 of those systems, and the policies at each one do vary somewhat. For instance, at one of the at the university, there is a mandatory mask-on policy within the facilities, whereas at the private hospital legacy system, it's an optional mandate. So there are things that are slightly different between the two hospitals where I work. Most of the preparation has gone around preserving PPE, and we have every night an email that comes out that tells us what the stock is so far. And we know how many ventilators there are in our system, and we know what our potential stash of N95s and PAPRs and gowns is, and so forth. So much of what every policy that comes out is related to trying to save PPEs and what constitutes an emergent case and what constitutes an urgent case, and that's now being reviewed by triage officers, as well as trying to limit the number of people that go into each room for rounds, and to try to limit the exams in isolated patients to just one a day. And there have been efforts to try to make even those virtual visits and consults. So much of what we're doing is just preparing for the surge. Our residents, we try to have one resident and one fellow on and one attending at each hospital. And then we also have APPs that are on at each hospital. Our entire office staff at the university is virtual at this point. And we have, as been done elsewhere, all our virtual meetings for education and for our M&Ms and so forth.
Thank you. Yeah, we're going to get on to be talking about, all the different realignment of the workforce that's being done and some of the other issues you touched on. So thank you for that. Tony, did you want to talk about kind of flexing resources for adults? And the other thing that really comes up under this question is the approach to resource allocation when there is a scarcity of resources, and you may be starting to face that in the Washington area and certainly in New York, and have your institutions kind of outline policies about what to do regarding, who gets ventilators, who gets ECMO. Obviously, we don't expect too many pediatric patients to need those things, but those are scarce resources, for the whole population. So at some point, the pediatric population is going to be part of that discussion. So, I'd like to start maybe with Tony, but if any of you have been part of conversations like that at your institutions, it would be great to hear about that.
Yeah, thanks, Lauren. We so we were tackling it from kind of like the system perspective. The Mary Bridge is part of an adult system that has several hospitals on the western side of Washington and a couple on the eastern side. But additionally, there are only 3 major children's hospitals in Washington, and the state has asked us to be prepared to offload pediatric cases, especially pediatric surgical cases, depending on how the general hospitals and the adult hospitals are doing with the surge. So we're walking a fine line of being a resource for the adult hospitals in case they do have to unload, relatively healthy young adults to us. And we are prepared to take up to the age of 30. But although it's in a tiered approach, so we would probably start off with less than 21 and then move our way up, and then still have capacity to be able to handle the rest of the kids in Washington, should that need arise. But in regards to scarce resource allocation, this is a huge topic of conversation. And we have 2 coalitions, regional coalitions, one's on the western side and one's on the eastern side of the state. And myself and many of the medical community are members of one of these coalitions. And since I happen to be a trauma medical director, I've been heavily involved in disaster preparedness for a long time, along with people like Chris Newton, who hosted last week's. And so we're having serious conversations about what happens if our, needs exceed our ventilator numbers, or for ECMO, what if the circuits don't seem to be an issue so much as the machines don't seem to be an issue as much as the tubing, and those kind of things that need to be produced where we're facing shortages. And so for the time being, we're continuing to do ECMO if we need to on kids across the state, but I anticipate that there may be a need to have that discussion if the adults start needing to use it heavily. The statistics I've seen are dismal in terms of if an adult has to go on ECMO for COVID. But nevertheless, I know that some people still consider it. So that's how we're distributing our resources right now. There's a heavy regional and statewide approach to how we're managing it.
Thank you. I wanted to give Dave Mooney a chance to comment on the last couple areas we were talking about. You mentioned in Boston, it's more that you guys are taking on regionally a lot of the pediatric patients, I think similar to how Columbia is doing in New York City. But have you had any conversations about flexing for adults or around reallocation of scarce resources?
We have, and one of the, our group covers another one of the hospitals in Boston. We're an only hospital, but there are several mixed adult pediatric hospitals. One of them now has shut their PICU to kids and opened it for adults, and now those PICU patients are coming our direction. And a couple of the other hospitals have shut down their smaller pediatric units, and now we're taking care of those patients. And the regional plan, which would probably be a first for Boston to actually cooperate at this level, would be to have the children come to our site. We haven't discussed a flex up age yet. We typically go to 21, and we've still, been holding at that. But for right now, that we would be the pediatric site that would decompress the pediatric units from the other facilities. But we've talked about ECMO, and we've prepared to back up. The Brigham is right next door, and we've talked about backing up the Brigham for ECMO because we do a lot more of it than they do. And whether those adults would come to our place, which we've done before, or we would head over to the Brigham and help with the cannulation and the maintenance. It hasn't happened yet, so we've still been talking about and doing simulations on how exactly that would work. Boston luckily has a wealth of medical resources and a lot of patients that come from other places to Boston for their care. And so far we're okay with beds. We're not in the same sort of state as New York. And we're not expecting our peak to be as high, and we're thinking about 2 weeks from now, which is I think a lot of places are looking at. And so far it looks like we'll skirt by. But one interesting thing about our place, we've talked about, should we test kids who, there's a kid Rusty Jennings was doing a very difficult airway case on. Well, with an airway case, everyone in the room has to have an N95 right through the procedure. And it's an many hours long case. And they talked about testing this kid to save the N95s. Well, currently we're short test kits. And we have the kits, but we don't have the reagent. And so it wasn't deemed, I guess we have enough N95s. You can get one from the OR desk. You can check one out from the OR desk. But we're short testing. And just a quick anecdote, I was in Florida about 9 days after I got back. At the start of March, I got a runny nose. And it was turned into a cough. And I'd been with a bunch of docs from other countries. And so I got tested for coronavirus. And I left the hospital, I had to leave work. It took 10 days for my result to come back. And I was just incapacitated, I was fine physically, but I couldn't go in the building until my test came back.
Right. Yeah, no, I definitely want to spend a bunch of time talking about what everybody's doing in terms of pre-op testing, because there are some hospitals that are routinely checking every kid for coronavirus before they will operate on them for the exact reasons you described about PPE preservation. But we have a late addition to the panel. Dan Osley has joined. So Dan, are you able to, I don't see you you want to just take a moment to introduce yourself?
Yeah. Dan Osley, I think I know everybody. In Phoenix Children's Hospital Surgeon-in-Chief.
So the topic we have covered so far before we move on to kind of changes to clinical practice and OR procedure that Dave Mooney started to get into is how your system is flexing to take care of adults, if at all. What kinds of conversations are happening? Are you expanding the age of patients that you care for to include some young adult patients? Are you modifying trauma protocols to accept traumas up to a higher age? There's a lot of different things going on around the country, so we'd like to hear your perspective on flexing for the adult surge.
Well, our governor mandated that we take anybody up to 21. So we're prepared to do that anyway. We don't turn kids or older patients away up to that age group, especially in patients that are complex medical patients that are ours. But he's mandated we have to be able to take care of any patient, not just trauma patients. We have a surge plan that we've been working on with the rest of the state. Our CMOs have all been working together to coordinate all of the pediatric care to come to Phoenix Children's Hospital from around the state, to include places like Flagstaff, which is about an hour and a half to the north of us, and Tucson, which is 2 hours to the south. And we've actually had to implement that at Flagstaff. They've had a big surge of COVID positive patients from the reservation. And they've got about 30 COVID positive patients in their hospital right now. And so they've closed their peds practice entirely, and they're sending all their pediatric patients to us. We're prepared as an institution to take people up to 30 in the ICUs. Our intensivists in both the CVICU and the PICU have agreed to take up to 30. And that's our anticipation if we have to. We're like everybody else, with the exception of New York, New Jersey, and Northern California. And we're prepared to be prepared at this point, and just waiting for the surge to happen. And based on the projections, it's not going to happen until the end of April. As I assume we've done everything that everybody else has done. We're not doing any elective cases anymore. Our cases volumes are down to about 60 to 65% on a daily basis. In order to preserve PPE, we're using full PPE for all respiratory patients, as well as any EMT or aerosolizing procedures that might be happening in the sinuses, or for ENT or neurosurgery or plastics. We cannot test. We don't have the ability to test. We have to send our tests all to the state at this point. We've got the machines to test, but we can't get the kits. So we're dependent on, kind of back to Dave's point, we're kind of 7 days. We're not getting any kind of turnaround. So ideally, we'd like to be able to test every child that goes to the operating room, and that's our plan if we can get the kits. But presently, we're not. We're testing kids that are in the hospital that are symptomatic and waiting for them to come back, and we're just treating kids that are symptomatic that we don't know if we have to operate with full PPE. We've divided at least most of our service lines have been divided into teams, which I think most people have done. So we've got 2 or 3 teams in every division, and you're on campus, off campus. And we've converted about 85 or 90% of our ambulatory services to telehealth. So we run about 16 to 1,800 visits a day normally through the hospital system, and we're seeing about 12 to 1,400 all being done by telehealth now. So we've had a really successful push in the telehealth market. We had some internal IT people that were able to build a platform for us that's actually being able to be used pretty well and sustainable in a large volume. So, I think that's kind of like a broad update of where we're at in Phoenix.
Thank you. No, that's great. So I wanted to kind of hone in a bit on what many of you have talked about a little bit, which is kind of the nuts and bolts of day-to-day operations in the hospital. We can start with the operating room. A couple of you have mentioned already. So I'd like to hear about what protocols people have in place regarding, first of all, how are you approaching any OR patient? A patient who comes in with appendicitis, are you operating on them? Are you more likely to do non-operative management than you would have been before? Are you testing them? If so, how long are you getting the results back within? Are they sitting in the hospital for 2 days while you're waiting for a test? If you're not testing them, are you presuming everybody's positive, or a person under investigation and using full PPE? So we'll kind of start with that group of questions. How about Tony, do you want to start with those?
Sure, thanks. So we have not changed our practice in regards to operating on appendicitis. We still feel that that's the standard of care, and that's how we approach it. But we've been really mindful about what SAGES is saying about that unknown risk of aerosolization with CO2 insufflation. So it's been hard. Following Adam's comments last week about universal screening for ambulatory patients, I've been working hard to try to get that implemented, at least on the children's hospital side, although the adults really like that idea and want to pursue that as well. We've formed an OR leadership committee. I'm the head of the pediatric side in terms of the surgeons, and in collaboration with the adult and anesthesia and the OR leadership, and go through the urgency or emergency of the ambulatory cases. In regards to the emergency cases, like the ER to OR cases, our ability to test for COVID is twofold. We do have in-house testing, but that's being saved right now for the high risk PUIs. And so the in-house testing takes about 8 hours to come back for us. For the moderate risk, which I'd assume that the ambulatory patient population would fall into for surgery, that has to be sent to UW, or University of Washington, pardon me. And that turnaround time for us is probably going to be 24 to 48 hours. Although I will echo Dave's experience of taking several days when I personally got tested for COVID-19, which came back negative, but it was several days before I heard anything back. In regards to the emergency cases, our hospital still has the policy that we're treating it as modified droplet. So eye shield, regular surgical masks, gowns and gloves, except for the high risk aerosolizing procedures like a bronchoscopy or intubation, in which case the first go-to are actually cappers. One of my partners operated in one of those and it was a disaster. The entire shield fogged up and they had to break through into that sterile environment to wipe out the shield. So that isn't going to work. Our hospital had stopped testing for N95s years ago. So another issue that has arisen as we're working to get fit tested is the lack of the solutions, the bitter and the sweet solutions that have to be used to be able to fit test N95s. Apparently that's also on shortage. So the surgeons are now deemed a high risk population and are going to be tested, but we have not been tested yet. And it begs the question about the recent JCO report that states we could bring in our own N95s from home. I don't know, our hospital hasn't addressed that yet one way or the other, but it is something that I'm personally considering. So that's kind of where we are in terms of surgical OR staff or processes.
Another quick thing to add to that list of questions is you mentioned obviously aerosolizing procedures are higher risk, and there are some places that for intubation in the OR are kind of doing that in a separate room or having everyone step out of the room and then wait a period of time. Have you changed any of your practices around intubation? And similar to in the OR, that could apply in the trauma bay in the ICU. Has there been any adjustment in the process around intubation in suspicious?
We have.
Positive, yeah.
Yeah, we have. We have a negative pressure room in the adult ACU, which we're utilizing for every intubation for a moderate or high risk patient. Not for every patient. If they're asymptomatic, we're still treating them as modified droplet, although some of us have reservations about that. Additionally, we happen to have an older OR that's not been functional for a while, but happens to have an anteroom. And so we're converting that into a second, essentially a staging room, and converting it from positive to negative pressure so that we are able to intubate an additional set of patients in that room. In terms of trauma, that's been a huge topic of conversation. And so we are looking at, we are using modified droplet precautions for every trauma. We're assuming every trauma is positive and treating them as such. And if they have to be intubated, then we're having conversations about having to either wear the full capper or N95 and moving the trauma patient over a couple of rooms down to our negative pressure room, although we have not come to an agreement on that yet.
Thank you. Dave, Mooney, do you want to address some of that?
Yeah, I mean, I think what we're doing sounds pretty similar. The one thing that is just to add, after an aerosolizing procedure, including intubation in the operating room, no one can be in the room without an N95 for 30 minutes after intubation. So for a case, you're just going to wear an N95, unless it's a case that takes a lot, there's an epidural and 12 other things that would have prolonged anesthesia time. I don't know where that number came from, and I've heard different lengths of time that institutions are using for the time that people need to stay out of the room. But it's really, there's a list of aerosolizing procedures, including, by the way, lower endoscopy has now been added to the list of procedures that needs an N95 mask. But again, we've tried to decrease the number of personnel in the room, not have trainees do intubations, have the attending staff do it. And it's very similar.
Art, what about you in New York?
Yeah, both our mayor and our governor have decreed that there should be no elective operations done. We certainly are standing by that at our institution. So no elective surgery is going forward. In terms of emergencies, we have not modified our